Well, Surgeon Dr. Amir Glani is there, and today I will teach you the nutrition on the surgical floor. I will not discuss the theoretical details, I will just discuss about the practical implications, and you will apply this data in your ward, especially in your daily rounds. And if you have a patient who needs the nutritional support, so you will be able to write in the charts. So let's start. Nutrition for a surgical patient. So first step is the nutritional assessment. Definitely you will select the patient whom they will need the nutritional build-up. So there are some parameters like on history and examination, and anthropometric measurements like weight, height, body mass index, and definitely you will do nutritional build-up for the underweight patients. The BMI will be less than 8.5. And skin fold thickness, normal value is 9 to 11 mm, and mid arm circumference, its normal value is 26 to 29 centimeter, and the clinical assessment and we use the MUST tool. Anyways, you can take the screenshot and you can memorize, but we are moving ahead. And there are some lab parameters also you are seeing on your screen. They are lymphocyte count, albumin, transferrin, pre-albumin, and retinol binding protein. I am not going to the details of these. You can pause the video and you can take the screenshot. I will discuss more the practical implications basically. So this slide is important. Indication for nutrition. If the BMI is less than 18 or skin fold thickness less than 9 mm or any other parameter which is fulfilling for the nutritional build-up. And there is also a group of patients who are at the risk of malnutrition, like in case of GIT malfunction, like in case of obstructed CA esophagus stomach stricture, paralytic ileus, in case of the high output fistulas, and in case of the small bowel disease like Crohn disease, acute severe pancreatitis, and too short gut syndrome, and post-operative NPO. If you are prolonging the NPO for more than 5 days, then it's an also indication for to start the nutritional build-up. And in case of the major polytrauma burn patients. So you can pause this slide and you can take the screenshot. This is also an important slide. Again, you can take the screenshot. How will you calculate the caloric requirement? The most commonly used, you can say that equation, it's the Harris-Benedict equation. For this equation, you need weight in kg, height in centimeter, and you will put both these values and you can calculate the basal energy requirement. And likewise, different other tools are there. Mifflin-Jor equation is there. Catch-McCarty equation is there. And then Cunningham equation is there. Again, you will just put the values and you can have the results. So total caloric requirement is equal to basal energy requirement multiplied by the activity factor and injury factor. Again, for different conditions, injury factor and activity factor, it is different. You can just put the value into total energy need equation and you can get the results. And one thing at this point I must tell you that in case of TPN, or you are building the nutritional status, the kilocalories and calories have got the same meaning. It is not different. So you will not be confused, inshallah. So again, caloric requirement on the surgical floor where intention is to increase the weight. Definitely patient will be underweight. And you have calculated the total basal energy expenditure we have shown in this slide exactly. When you will find the results by this equation, you will add at least 500 kilocalories in total calories calculated, because our intention is to increase the weight, not it's the maintenance basically. And again, the most important thing, you will continue this regime for 1 week. After that, you will assess the weight of the patient and you will again use that current weight in the again Harris-Benedict equation and total energy requirement and again you will continue, you will add 500 into that equation, and you will continue for 1 week, and this system will continue on until your desired results. And finally, at the end, you will divide the calories into the different nutrients, and 50% of your energy should come from the carbohydrates, and almost 30 to 40% from the fats, and proteins it's 10 to 15%. And the protein requirement, it's normally daily requirement in a healthy patient, it's 0.8 to 1 gram per kg per day, but in case of moderate stress, it increases at 1.2 to 1.5 gram per kg per day, and in case of the severe energy, it increases to the 2.5 gram per kg per day. And here, so parenteral nutrition, its indications: when GAT tract is not functional or available and patient is a candidate for the nutrition, then you will start this. So this is the most important slide, and different solutions available which are in the market, and they are lipofundin 20%. Basically it's a lipid solution, and it's 250 ml. It will provide you 480 kilocalories, and its osmolarity is 380 milliosmol per liter, and you can give this regime by the central as well as the peripheral nutrition. So it's very important. When the osmolarity is high, you will use the central route preferably. If the osmolarity is low, you can use the peripheral lines. So if the osmolarity is almost 592 in case of minoplasmal 5%, then you can use central as well as the peripheral lines. But if it is 864, you will use the preferably central line. And definitely if more osmolarity is there, you will use definitely central line. You cannot use the peripheral line. It will result in a lot of complications definitely. So you can take the screenshot and you can memorize this. It will be beneficial for you. Like if we are using the minoplasmal 5%, it's 500 ml will be equal to 25 gram of protein, and its osmolarity will be 592 milliosmol per liter. So you can memorize all these things. Now parenteral nutrition, how we will calculate: a total of 2300 kilocalories are calculated for a patient weighing 46 kg. Here I am not choosing the weight 70 kg because a 70 kg person will be definitely healthy and he will not need parenteral nutrition or enteral nutrition or nutritional support. So we are using the Harris-Benedict equation, and we will divide into three components. Definitely carbohydrates 50%, half of the 2300, it will become 1150. Fats 35%, it will become 800 kilocalories, and proteins 15%. And protein, here we will give a 1.2 gram per day, so we will multiply it and it will come almost 53 grams. So we will convert these calories to the different solutions which are available. In the previous slide I have shown all these. For the carbohydrates, infusion of 25% dextrose water 1000 ml, it will provide almost 1150 kilocalories. And for the fat, we need 800 kilocalories, and we can fulfill this requirement by the infusion of lipofundin 20% 400 ml. Likewise, proteins 53 grams, we will use infusion minoplasmal 5% 1000 ml. So all our requirements, they will be totally balanced and they will be fulfilled by this regimen. Now how will you write these regimes in your doctor's order? Keeping in mind, dextrose should be given over a period of 24 hours, and proteins should be given along with dextrose for the protein sparing effect. Otherwise it will be used as energy source, it will not be spared, and we need to build up the weight. And lipids can be given separately, and total fluid being given at one time should not exceed 120 ml per hour. Almost it becomes 33 drops per minute. So write down the fluids as infusion 25% dextrose water 1000 ml IV and at 11 drops per minute, and infusion aminoplasmal 5% 1000 ml IV 22 drops per minute, and infusion lipofundin 20% 400 ml IV 22 drops per minute. So this is the right way to write the fluid in your round orders. Now the question arises, how will you start the parenteral nutrition? Definitely you cannot give the maximum calculated dose from the day first. So in a strategic way you will start it. From the day 1 you will give the 10 kilocalories per kg per day. But if a person is severely malnourished and a BMI is less than 14, then you will further reduce the dose to 5 kilocalories per kg per day. Likewise, from the day 2 to 4, you can give the 20 kilocalories per kg per day. Day 5 to 7, you can give 30 kilocalories per kg per day, and from day 8 to 10, you can give the full required strength or dose. So you are giving the parenteral nutrition, and how you will monitor this. So we have this table, the parameters which we have to monitor on daily basis, on weekly basis, and fortnightly basis. I will not discuss these in detail. You can take the screenshot of this presentation. You can take the screenshot of this slide especially, and you can memorize all these things. So we will not waste time. So how will you wean off? This is also most important thing. When the patient is able to tolerate the oral intake, then you can start weaning the parenteral nutrition. For example, in start, patient may start tolerating 500 kilocalories orally. So he may be taking 500 kilocalories orally and 1800 parenterally to complete the total caloric intake of 2300, which we have previously calculated for this patient. And you can stop the parenteral nutrition completely when 75% of the total calories can be taken orally. And definitely there are a lot of complications, and they are related to the nutritional deficiency, overfeeding, sepsis, and line. And nutritional deficiency like hypoglycemia, hypophosphatemia, hypocalcemia, hypomagnesemia in case of the refeeding syndrome, and chronic deficiency syndromes like of the fatty acids, zinc, and mineral and the trace elements. Related to overfeeding, there are also complications like excessive glucose, hyperglycemia, hyperosmolar dehydration, hepatic steatosis, and a lot of these complications you can read and you can memorize by just pausing the video here and taking the screenshot. And related to the sepsis are also there. Related to the line like pneumothorax, and remember at that point the chances of the pneumothorax, they are more with the subclavian route as compared to the other routes. And long-term complication like occlusion and the venous thrombosis, they also can happen. Now the second part of our you can say that lecture, that's the enteral nutrition. Till now we have discussed about the parenteral nutrition. So there are various routes. The best and the first route, that's the oral, and you can also use the nasogastric tube, nasojejunal tube, patch tube, gastrostomy, and jejunostomy. And there are various routes, and depends upon the condition of the patient and the predisposing factor. In rate of administration, you can give the bolus 300 to 360 ml rapid delivery via syringe several times daily, or you can use the intermittent 300 to 360 ml over 20 to 30 minutes several times per day via gravity drip or a syringe. And you can also use the cyclic way via pump, usually at night, and continuous via gravity drip or infusion pumps. And in case of enteral nutrition, there are also steps. First of all, you will confirm the tube placement in the stomach or jejunum, elevate the head and to the 45 degree, and you can aspirate the gastric contents, and if the aspiration is more than 50% of the last feed, then push it back and skip that feed. And if aspiration is less than 50%, then push it back and give this time feed as well, which you have calculated, and flush the tube with 10 to 15 ml of the normal saline, and keep patient in this position for minimum of the 30 minutes. And initiation of the tube feeding, start at 100 ml every 4 hourly and gradually increase amount or strength concentration. And how we should cease the tube feeding: when a patient can tolerate 75% of the total caloric requirement, enteral feed can be stopped. So there are various complications. I will just scroll the slides, and if you are interested, you can take the screenshots and you can memorize this. Tube related complications are there, then GIT related complications are there, then metabolic or the chemical complications like electrolyte disorders, vitamin, mineral, trace element deficiencies are there, drug interactions are there, and infective, it might be exogenous, it might be endogenous. So thank you so much. Hope you have learned something from this video, and you have learned something from this video. If it was beneficial for you, then do subscribe my channel Surgeon Dr. Glani and keep supporting educational content, and don't forget to press the bell icon for further updates from this channel. So thank you so much for your patience for this much time.